Okay, today we'll be talking about diuretics and pharmacomanagement of certain renal diseases. First of all, what are diuretics? Basically, they're a drug type that acts to increase the excretion of water from the body. It may be used in certain conditions, such as heart failure, to reduce preload on the heart. So, first of all, we'll be looking at the drugs that attack the proximal convoluted tubules, and these are known as our osmotics, and a drug name of this class is mannitol, and basically it performs its action via increasing osmolarity within the tubule lumen of our renal tubules. This therefore decreases the osmotic gradient between the inside of our tubule lumen and the surrounding interstitium, thereby decreasing the amount, decreasing the osmotic gradient, and thus the amount of water that is reabsorbed back into the body. This is a caveat of this is that it is only used for local edema situations, such as there being a high increase of fluid within the brain. And as we know, the brain is a closed, encapsulated space, making a swell quite life-threatening, and this is one of the mechanisms in which they can try and reduce the amount of fluid present. Next, we have diuretics that act at the loop of Henle. The ones to remember is furosemide, and it acts via inhibiting our sodium, potassium, and chloride transporters. And by doing so, as there is more sodium present in, as we know, the osmotic gradient is then decreased. The difference between the lumen and the interstitium is decreased as there's more sodium or more solutes in the luminal fluid. Therefore, water does not passively diffuse across the membrane and back into the interstitium. However, as we are blocking our potassium reuptake, this causes hypokalemia and can lead to life-threatening arrhythmias. Next, we have our thiazide diuretics, and they're basically the main one to remember is our hydrochlorothiazide. And this acts at the distal convoluted tubule, and it inhibits our sodium chloride transporter. As a result of inhibiting this transporter, we also get increased upregulation of other transporters within the epithelial cells to maintain the electronegativity of the cell. And because of this, we also see decreased secretion of calcium ions, and therefore it can lead to conditions of hyperkalemia, as well as cause hypokalemia. Next, we have the ones that occur in our collecting duct, known as spironolactone. This is an aldosterone antagonist, and it basically blocks the effect of aldosterone on the epithelial cells in the collecting ducts and the distal convoluted tubule, and it does this by reducing the expression of our sodium channels present on the apical surface of our renal tubules epithelium, and as such there is a decrease in sodium reuptake and therefore decreased osmotic gradient, therefore reduced reabsorption of water. However, by doing so, it results in hyperkalemia, as sodium is exchanged for potassium when being reabsorbed into the body in this specific instant at the collecting ducts. Another one of these drugs that are potassium sparing is amiloride, which is basically a pure sodium channel blocker. So spironolactone acts to prevent the production of our sodium channels, whilst amiloride blocks our sodium channels. Next, we have the treatment of UTIs, and it's just a pharmacological treatment, and basically it's high fluid intake to prevent acute kidney injury due to blockages and inflammation. We use urinary alkalizing agents to decrease the burning sensation, as many of these bacteria causes increased pH, and therefore we try giving them alkalizing agents to decrease the burning sensation. And the key treatment process in a urinary tract infection is that of treating the bacteria or pathogens that are causing our infection, and that is with antibiotics. The key one that we use is trimethoprim for uncomplicated lower UTIs, as it's a broad spectrum antibiotic that has good coverage and kills basically most of the bacteria that could cause a UTI. However, if the bacteria has spread far up into the ureters and up into the kidneys, we get a situation of pyelonephritis, and this is a life-threatening situation where IV antibiotics is required ASAP, as this can lead to sepsis quite quickly and the patient can deteriorate rapidly. Patients that have frequent UTIs may require prophylactic antibiotics to prevent them, as they're predisposed to getting infections, and prophylactic antibiotics can prevent progression into pyelonephritis. Next, we have the treatment of glomerulonephritis. As we know, glomerulonephritis refers to a collection of diseases involving immune-mediated injury to the glomerular filtration barriers, which cause deterioration of these barriers, leading to proteins and particles that aren't supposed to exit the bloodstream to exit into the tubular lumen, basically making the filtration system redundant. In terms of treatment, it's split into two. First, it's treating the root cause of it, which is the immune-mediated injury. So we use prednisolone to reduce the inflammation caused by these immune complexes for attacking healthy tissue. And then we use immunotherapy through drugs such as rituximab, which is an antibody, and cyclophosphamide to limit the production of immune cells to reduce damage of the glomerulus further. In terms of general treatment, this is mostly symptomatic treatment, as many of the patients will suffer hypertension and oliguria, as well as hypercholesteremia. So we treat these accordingly with antihypertensive diuretics and statins.